Hello, everyone, and welcome to today's Keynote webinar titled Keynote Presentation, Implementation of Serological and Molecular Tools to Inform COVID-19 Patient Management. This webinar is part of the 13th Annual Clinical Diagnostics and Research Virtual Event, and I'm Susie Valdez of LabRoots, and I will be your moderator for today's event. Today's educational web seminar is presented by LabRoots. So let's get started. Before we begin, I want to remind everyone that this event is interactive, and we encourage you to first participate by communicating with other attendees using our new live chat feature during the presentation. You can find that live chat located at the left of your screen. You can also participate by submitting as many questions as you want during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. Now, if you have any trouble seeing or hearing this presentation, just click on that help desk button located at the top of your screen within the navigation bar or from the lobby. And finally, as a reminder, this presentation is educational and offers free continuing education credits. Click on that continuing education credits link located in the abstract tab from the menu on the left at the screen and follow the process to obtain your credits. I now present today's speaker, Dr. Jennifer Taher, clinical biochemist at Mount Sinai Hospital in the Pathology and Laboratory Medicine, and an assistant professor at University of Toronto in the Laboratory Medicine and Pathobiology, and then a co-lead for the GENCOV COVID-19 Prospective Clinical Research Study. For a complete biography of our speaker, please visit the presenter tab from the menu at the left of your screen. Dr. Taher, welcome. You may now begin your presentation.
All right. Thank you to LabRoots for inviting me here today. So today I'm going to talk about our GENCOV study, which is called Implementation of Serological and Molecular Tools to Inform COVID-19 Patient Management. So I have a few disclosures. And as an overview for today's talk, I'll start by introducing what GENCOV is by talking about the study team and the protocol. I'll next talk about the patient characteristics of our different cohorts and the biochemistry lab data that we are collecting. I'll briefly touch on knowledge and understanding of COVID-19 serology results, and I'll also present some acute and long-term serological findings in our cohort of COVID-19 patients. So what is GENCOV? GENCOV is a COVID-19 prospective research study that spans 8 hospitals in Ontario and includes a multidisciplinary team of several co-investigators and collaborators. GENCOV was initiated by myself. I'm a clinical biochemist, as well as Dr. Jordan Lerner-Ellis, who's a molecular geneticist, and we're both located at Mount Sinai Hospital in Toronto, Ontario, in Canada. So the overarching question that we are trying to answer is, why do some patients respond favorably while other patients respond unfavorably to COVID-19? And we think that this is due to 3 factors: the immune response of the individual, the viral strain that they are infected with, and the genetics of the individual. So to address this, we have 4 overarching aims to our study, and today to focus on aspects that are related to aim 1, which is to identify the characteristics of the antibody and T and B cell receptor response that result in maintained immune response and better patient outcomes. The other aims of our study include to determine the impact of genetic differences on COVID-19 infection severity and immune response, to determine the impact of different viral strains on antibody response and patient outcomes, and lastly, to evaluate patient-reported outcomes of receiving host genome, antibody, and viral lineage results. But again, today I'm only going to focus on aim 1. To complete these aims, we decided that 1 clinical biochemist and 1 molecular geneticist just wouldn't be enough. So we recruited more than 20 co-investigators and collaborators from various hospitals and institutions in Ontario. This includes pharmacists, nurses, physicians across many different specialties, including infectious disease, emergency, and ICU, as well as many laboratory experts across many fields, including biochemists, microbiologists, and geneticists, and researchers from various areas of expertise. We also have a core research team located at Mount Sinai Hospital that includes graduate students, research assistants, genetic counselor, bioinformatician, statistician, and volunteers. And I'd like to specifically thank Gregory Morgan, DeWitt Walday, and Jordan Fung, who performed most of the analysis that I will be showing today in this talk. Okay, so between May 2020 and April 2022, we recruited adult patients into our study into what we call the COVID cohort. And they were recruited into this cohort and had a positive PCR swab. This was performed mainly via phone calls that were part of routine clinical care in Ontario to outpatients to follow up on PCR results, or by directly asking inpatients that were hospitalized. Recruitment occurred at Sinai Health, William Osler Health System, the University Health Network, Women's College Hospital, as well as Mackenzie Health. And we're very excited to be the only study recruiting from the first COVID-19 designated hospital in our province, which is Mackenzie Health. We recruited a total of 1,478 patients, of which majority were outpatients. However, of note, we did have a significant number of inpatients, and there is a portion of this population that was deceased. We also have a vaccine cohort, and this includes adults with no previous COVID-19 infection, but they did receive a Health Canada approved vaccine. Now, this cohort was incredibly hard to find, and we did do this by contacting people who agreed to be consented for research when they were vaccinated. Okay, so I'd first like to start by discussing the GENCOV protocol of how we were set up to recruit and collect samples. GENCOV currently has 3 protocols that are published, shown here. I'm going to focus on the first one, which is just the general outline of how we collect information in our participants. And the other 2 published protocols focus on genome reporting, which I will not discuss today. Okay, so the initial aim of our study was to recruit around 1,500 individuals, which we were pretty close. And these individuals were patients with mild or severe COVID-19 based on whether they were outpatients or inpatients. And then at the baseline measurement, which is what I'm showing here on the slide, we collect a blood sample, which is shown by the blue boxes, and that's used for serological testing as well as T and B cell receptor sequencing. Most commonly, blood at baseline is only collected for inpatients because we didn't have access to outpatients at that time. And we also receive the viral swab, which is shown in the red boxes, and we use that for viral genome sequencing to determine the viral strain that the participant had. And lastly, in yellow, we gain access to the patient chart to collect data on labs, symptoms, clinical conditions, medications, and patient outcomes. And we also hand out a survey at baseline when they consent into the study to collect information on demographics, clinical history, result return preference, and understanding of results, because we do return results back to these patients. So at the 1-month time point, another blood draw is performed, again shown in blue, for serology and T and B cell work, as well as for host genome sequencing. And this is only performed once on the participant. And at this point, we start returning the serology results back to the patient. We don't yet return the results back for the genetic sequencing, because first they meet with our genetic counselor to discuss the type of results that they would like to be returned. The genetic results are returned at the 6-month time point where a follow-up is booked and patient outcome measured are assessed, where we hand out surveys to understand the impact of returning these types of results back to our participants. At 6 and 12 months, we continue to do 2 more additional blood draws to assess serological and T and B cell receptor response longitudinally. So this is the vaccine cohort, which I won't show too much data on this cohort today. But in this cohort, serological and D and B cell receptor sequencing is done at 1, 6, and 12 months after each dose of a vaccine. If they get another dose within this time frame, then it's reset back to collecting at 1 month since their most recent dose. And you'll see later on that some of our COVID cohort did get vaccinated, and they do start to collect blood samples after their infection as well as after their vaccinations. So now I'm going to talk about some of the demographic data that's collected from our patient surveys. We handed out 1,106 surveys, and we received 967 responses back, which is an 87% response rate, and we thought that was pretty good. So in our cohort, there's approximately an equal number of males and females in the study, and we see that most respondents fall between the ages of 25 to 64 years of age. Unfortunately, we do have bias in the ethnicity, given that most of our cohort is white and European, despite collecting from hospitals that have significant ethnic diversity. So we're not sure if there's bias in populations to willingness to participate in research, but unfortunately, due to this bias, it has led us to do our analysis based on comparing white European participants with all other ethnicities combined. Additional variables included education, employment, as well as household income. And you might be asking, why would a clinical chemist care about these variables? And the answer is that it actually relates to how well people can understand their laboratory results. And I'll touch on that briefly later. But looking at the results, we do have diversity in education level, which ranged from people who had high school or less to people with a master's degree or higher. Most people had a bachelor's or 4-year college degree. For employment, we asked whether people were healthcare workers, as we thought this could increase their risk of COVID-19. And we had a small but significant percentage of healthcare workers in our cohort, and this included long-term care workers as well. Lastly, we assessed household income, where we had majority with a household income greater than 100,000, and the remaining was split between people who had 60 to 99,000 and those with less than 60,000. Okay, so regarding our vaccination status, initially the study started out with a very clean protocol. However, the complexities of COVID-19 created multiple subcohorts because our vaccinated cohort started getting infected and our infected cohort was getting vaccinated, and we didn't interfere with any of that. We advised our population to please follow health guidelines and recommendations, but it did create sub-cohorts in the study. So we defined subcategories, as you can see here on this slide, as infection alone. If a patient was infected with COVID but did not receive any vaccine, they were considered as breakthrough if they were first vaccinated and then infected, and hybrid if the participants were first infected and then vaccinated. Unfortunately, we have a significant number of participants with unknown vaccine status. Now, almost all of our disease cohort, we were unable to determine their vaccination status, which is a large contributing variable to this unknown status here. However, you can see here with these cohorts that the hybrid infections are further broken down based on the number of doses and when they received a vaccine dose. So was it before or after their blood collection time points, which I'm showing on the right-hand side of the slide. So here I'm showing a simplified version of the timelines that we performed. But here is our complete cohort where we account for all scenarios that were recorded. And it's truly quite complex, but I will show you data later on, antibody data that we analyzed from these different sub-cohorts. And to complicate things even more, there are, of course, different types of vaccine combinations that people received in our study. Although we had majority of the cohort receiving Pfizer, there was a significant proportion also receiving Pfizer and Moderna, 11% receiving Moderna only, and then we had about 10% receiving other vaccine combinations, which included AstraZeneca, Johnson & Johnson, or Novavax. We also have different number of doses, and I don't show the complete breakdown based on every single combination here, but overall, of our vaccinated participants, the majority received at least 2 doses, about more than half received at least 3, and we had a very small portion that received the 4th dose or more. Okay, so that is the patients that we have included in the study. And now that you can understand our patient population as well as our protocol, next I'm going to show you data of the clinical characteristics and symptoms that we assess and how those differed between our inpatients and our outpatients in the study. So here you can see in the chart, we have collected additional data from patients. I've already shown you sex, age, ethnicity, and vaccination status, but we also collected BMI, viral variant, comorbidities, as well as a history of smoking. Now, in the chart, in the first column, we're looking at the total number of individuals, and in the latter 2 columns, we're looking at how this is divided between first the inpatients and then the outpatients. And finally, in the last column is the p-value, which highlights the significance. So differences here were observed in age, where inpatients were older than outpatients, which is expected. However, it was really interesting to see that 65% of the inpatient cohort was less than 65 years old, with a median age of being around 55, and we thought that that was notable. Inpatients were also more likely to be white and European, had a higher BMI, and also reported having more comorbidities. Of note, however, 32% of our inpatient cohort actually had no comorbidities. We see a non-significant trend in the vaccination status where inpatients were more likely to be unvaccinated, but there was also a great proportion of outpatients that were also unvaccinated. And interestingly, there was no differences in sex or history of smoking. So next, we ask the question of how clinical characteristics impact your odds of hospitalization. And we did a univariate logistic regression and Crude's odds ratios for our continuous variables like age and BMI. And the disorder categories that are listed here at the bottom, such as lipid conditions, hepatic conditions, blood conditions, these have several subcategories that were developed in conjunction with our clinical experts on our team. So the variables that we found to be significantly increasing the odds of hospitalization included being older, being non-white or European, having a higher BMI, being infected with a viral variant, being unvaccinated, having hypertension, or having disorders that are related to endocrine conditions, including diabetes, cardiovascular diseases, cancer, lipid disorders, or hepatic disorders. Of note, while there's evidence in the literature that autoimmune and neurological conditions can be induced by COVID, Having these pre-existing conditions didn't increase the odds of hospitalization. Also of note, history of smoking and pulmonary conditions also did not increase the odds. So instead, we actually find a stronger relationship with characteristics that belong to the metabolic syndrome. We next repeated this assessment, but we used a multivariate analysis to determine the effect of individual comorbidities on hospitalization and controlling for factors that we found to be associated with severe COVID in the literature. So that included age, sex, ethnicity, smoking status, BMI, hypertension, diabetes, cardiovascular conditions, and respiratory conditions. When we controlled for these variables and redid the analysis, we still have significance for age, ethnicity, BMI, viral variant, and hypertension, but we lose significance for the vaccination status, the endocrine conditions, diabetes, cardiovascular disease, cancer, lipid disorders, and hepatic disorders. So it's really these variables at the top that are increasing the odds of hospitalization in our patients. Next, I'm going to briefly describe the type of biochemistry and hematology labs that we collect in the study. We decided to use the initial International Federation of Clinical Chemistry laboratory test recommendations that were released in early 2020 when choosing labs of interest to assess in our patients. We did not perform any additional testing on these individuals. We just collected the hematology and biochemistry data that was performed as part of their routine clinical care. So from our initial analysis of 128 inpatient charts, we looked to see how commonly labs are being ordered and then classified them by very frequent in red, frequent in blue, moderately ordered in purple, and not commonly ordered in black. We can see that very frequently ordered tests on COVID-19 inpatients include electrolytes, creatinine, glucose, CBC, and bicarbonate. And these were often ordered more than once in the same patient. The next most commonly ordered test included liver panels, bilirubin, CRP, urea, and pH. So it's apparent that renal and liver assessments are common in these patients. But interestingly, the number of bicarbonate requests was significantly higher than that of the blood gases. Overall, we do find that acid-base disorders are frequently assessed in these patients. Looking at the moderately ordered tests, this included base success, D-dimer, albumin, blood gases, ferritin, troponin, and lactate. And we noticed that ferritin was often being used in these patients to assess inflammation. The other markers also suggest investigations of cardiac and coagulation disorders, as well as sepsis and ischemia. While markers of other markers such as BNP and NT-proBNP looking at heart failure were not commonly investigated. Now, what if we look at the rate of abnormalities in these tests? Now we see a different story. So I'm going to change the table around so that you can see it from the most abnormal to the least abnormal. Okay, so we can ignore triglycerides because there was only 2 tests done. And we haven't yet calculated abnormality for CBC because it requires abnormality for a number of tests. We see that the most abnormal tests were those that were moderately ordered and included albumin, followed by D-dimer and blood gases. So this suggests that coagulopathies and blood gas disturbances are common. The albumin being decreased 96% of the time was rather interesting, but keep in mind that percent abnormal relates to how the patient value corresponded to the reference interval. And we did see that for many markers that there are values that lay just outside of the reference interval, which is something we need to look further into with our analysis. And this data also includes repeat testing. Okay, so there are some limitations, but nonetheless, we do see significant or abnormal rates with glucose, prothrombin, liver enzymes, pH, CRP, and troponin, again suggesting that liver, acid-base, cardiac, and inflammatory processes are ongoing in these patients. On the lower end, there was not as much abnormality with the electrolytes, bicarb, APTT, and bilirubin. So overall, we are seeing that the frequency of testing doesn't necessarily correlate with the abnormality rates, but the most commonly investigated and abnormal tests were liver markers, blood gases, cardiac tests, coagulation markers, inflammatory markers, and assessment of acid-base disorders. Of note, renal markers were much more commonly ordered than they were abnormal. All right, so in the next half of my talk, I'm going to touch on the serological analytical methods used in our study. I'll give a brief introduction to put some of the information into context, and then at the end, I'm going to talk about some of our serological findings. So the COVID-19 virus has 4 structural proteins, but most of the assays that we use target antibodies against either the spike protein or the nucleocapsid protein epitopes, with several of the spike assays targeting specifically what we call the receptor binding domain, and I'll refer to that as the RBD throughout the talk. And the RBD is what's needed for the virus to bind to ACE2 on the target cell to allow entry. Now, antibodies typically are produced within 10 to 14 days after symptom onset. And we see a rise in IgG and IgM, and we would expect IgM to fall more rapidly over time. Now, note that IgA is also an isotype, but it's not shown here in this slide because it's not measured in a clinical setting. And most Health Canada approved assays are for the IgG or the total antibodies. However, we do use IgA in a research setting, and we have used it in our study as well. In the GENCOV study, we used 2 serological types of assays. So the first one are Health Canada approved Roche assay for testing total antibodies, which means that it detects all isotypes, the IgM, the IgA, and the IgG. And we use a qualitative assay for the detection of antibodies targeting the nucleocapsid, and a semi-quantitative assay for the detection of antibodies targeting the spike antigen, and it's specifically targeting the RBD. It's an electrochemiluminescent immunoassay that is a double antigen sandwich, and it is used in the detection of the total antibodies. We also use a research ELISA that was developed by Dr. Anne-Claude Gingras at the Lunenfeld Institute in Toronto. And this ELISA is used because it helps us to better characterize the antibody response, because it can differentiate the 3 different types, 3 different isotypes, IgA, IgM, and IgG. And it also has 3 different antigen targets, the spike, the RBD, and the nucleocapsid. The details of the assay are published in Science Immunology, and it's been validated against the National Microbiology Lab, the Canadian Blood Services, and the Toronto Invasive Bacterial Disease Network. They've also developed a surrogate neutralization assay, which is a competitive ELISA where antibodies compete with labeled ACE2 for spike binding. And the development of this assay and the details of it are also published in an early publication from 2020. All right, so next we did a method comparison between the Health Canada approved Roche assay shown at the top of this table and the research ELISA shown to the left, because we use both of these assays in the study. And we did this to assess how well the data would compare. So this is the comparison for the anti-nucleocapsid across both assays. And we calculated the percent positive agreement, negative agreement, and the overall agreement. And in the 4-way table, we have 1,249 samples that were positive on both assays and 102 that were negative on both. We did, however, have 33 samples that were negative on Roche and positive on the ELISA, and 111 positive on Roche and negative on the ELISA. So ultimately, this means that the percent positive agreement was very good, but the percent negative agreement wasn't as strong with the research ELISA, because the research ELISA didn't appear to be as sensitive as Roche, and often called a negative when Roche was positive in infected individuals. But we found this to be particularly true for the borderline cases, which accounted for most of the discrepancy here. We next compared the Roche anti-spike assay, which targets the receptor binding domain, and compared this with the research ELISA targeting the RBD as well. Here, we have a similar percent positive agreement compared to the anti-nucleocapsid assay, and a much better negative agreement. So overall, the comparison with the anti-RBD assays show a better comparison, although we did consider both assays to be acceptable for our research study. Now, before showing the actual serological profiles in our COVID population, I want to first discuss how well participants understood their serology results based on survey questions that we administered to them. So after enrolling into the study, patients were asked a series of questions that are shown here on the slide. And these questions were developed by the GENCOV team, and they assess different aspects of understanding lab results relating mainly to serology, but also to understanding viral strain. So we assessed if there was differences in understanding between looking at differences between sex, age, education, household income, and occupation. And you can see here for question 1, which is having COVID-19 antibodies means I'm protected from getting a COVID-19 infection in the future. In this question, sex was a variable that showed a significant difference among our cohort, where females answered more correctly than males. In question 2, which is having a positive COVID-19 swab and not having COVID-19 antibodies, means that I'm more susceptible to COVID-19 infection in the future. There was no differences between any of the categories. And in question 3, which is my COVID antibody results should always match the COVID swab results, there was differences in many of the categories, but of note, this was the only category where healthcare workers answered more correctly than others. And interestingly, there was largely no difference in the knowledge and understanding of serology testing and results among healthcare workers versus the general public. And I think this is surprising. So I won't go through all of the questions listed here on the slide, but instead I'll show you a summary of our findings. So overall, we found that participants who were female, aged 18 to 44, with higher education and higher household incomes answered questions more correctly. We were able to explain reasons for all of these variables except for the sex differences. We found it very odd that females answered more correctly on 6 out of 11 questions, although we did find that sex was independently associated with these differences. We think that there may be another factor that's not perhaps evaluated in this analysis, such as ethnicity, which may be confound this difference that we see, because we do not see sex differences in knowledge in other publications. So we do find this finding to be a little puzzling. If we disregard the categories and we just look at the overall analysis, we see that individuals overall had a very good understanding of positive test results in relationship to asymptomatic infection. They understood that the scientists' knowledge gaps related to SARS-CoV-2 antibodies. They understood serological test sensitivity in relation to post-infection timelines, which there's a lot of literature about, so that's great. And they understood how SARS-CoV-2 antibody status should not be used to influence social distancing measures. There was divided understanding on how positive serological test results relate to immune protection, about conflicting PCR and serological test results in the diagnosis of infection, serological test availability, as well as viral lineage and vaccine eligibility. And lastly, the cohort had a very poor understanding of conflicting PCR and serological test results and immune protection, how viral lineage may impact vaccine efficacy, and there was significant challenges with understanding that SARS-CoV-2 antibody results can differ from the PCR results. So to our knowledge, our study is actually the first to assess public knowledge of SARS-CoV-2 antibodies and serological testing. And we think it's very important because it enables us to identify common misconceptions in understanding these results. And it helps us to target populations that may be more prone to misunderstanding, including populations that are less educated or with lower household incomes. And so while we may have believed that populations did not understand test sensitivity, we see that they do. And we're now finding that it's actually discordant results between antibodies and PCR that are presenting more challenges to people's understanding. All right, so for the last part of my presentation, I'm going to focus on the results of the serology data that was obtained. So recall that the cohort can be broken down into 4 different groups. And the first set of data I will show you will be based on the infected cohort, which means they have not received a vaccine. So any blood draws that were performed in a COVID-19 infected person that has not yet received a vaccine. And this antibody data was analyzed first because it was the easiest data to interpret, because it was not complicated by all the overlying vaccinations. So samples were included in this analysis if the patient was confirmed to be unvaccinated or if the blood draw date preceded the date of the vaccination. And so you'll note that the numbers are smaller in comparison to the people we recruited because much of our cohort actually became vaccinated quite early on. Nonetheless, when we look at antibody data in this cohort, we assessed both positivity of both anti-spike and anti-nucleocapsid performed on the Roche platform, because we do expect in an infected individual for both of these antibodies to be positive. If only one was positive, we considered it a discordant result, and we broke down the analysis by comparing inpatients and outpatients at 1 month post-infection, but inpatients also had a baseline that was collected during their hospitalization. And what we see is that positivity increases between baseline and 1 month, which is expected. And by the 1 month time point, 100% of patients were positive for both anti-spike and nucleocapsid antibodies. Similarly, most outpatients were positive, and therefore there was no significant difference in the positivity rate between our inpatients and our outpatients. Of note, however, there was a very small portion of outpatients, around 2%, that had discordant results at 1 month. And the characteristics of these individuals on why they're only developing one antibody response is being assessed. Using the research ELISA, we could break down the assessment of the antibody isotype positivity. And for each isotype shown here, which includes IgG, IgA, and IgM, we assess the antigen target to the spike protein, the RBD, and the nucleocapsid. And compared to baseline, a greater proportion of inpatients at 1 month were positive for all isotypes, with the exception of nucleocapsid IgM. And this isn't surprising because we expect seroconversion to occur between this time point. However, compared to outpatients, a greater proportion of inpatients at 1 month were positive for several of the antibodies, including the anti-RBD IgA, the anti-nucleocapsid IgA, anti-spike IgM, and anti-RBD IgM. So this suggests that inpatients are maintaining an IgA and IgM antibody response for a longer time, or they have a more robust response. We next examined the quantitative distribution of total anti-spike antibodies as measured on the Roche platform between inpatients and outpatients at different time points. And here we see that inpatients at 1 month have significantly greater total anti-spike antibodies compared to baseline and compared to patients at 1 month. However, for both patient groups at 1 month, there was considerable heterogeneity in levels of total anti-spike. But taken together, inpatients appear to have a stronger antibody response, at least at the 1 month time point. And with outpatients, we do see a small but a significant increase in the antibody levels over time. If we break down the response by looking at individual isotypes, and here I'm showing the anti-spike IgG, IgA, and IgM for the exact same cohorts and time point. And also you can see the horizontal red line indicating the antibody positivity for the assay. We see similar results to the previous slide. So the inpatients at 1 month had significantly greater levels of all anti-spike isotypes in comparison to the baseline and compared to the outpatients at 1 month. However, one difference is that the outpatients at 6 months had lower levels of anti-spike IgA and IgM compared to 1 month. And there was no significant difference in the anti-spike IgG levels between these time points, but we do expect IgA and IgM to decrease with time. So moving on to looking at now the anti-RBD IgG, IgA, IgM for the same cohort and same time points. Again, we see very similar findings. Inpatients at 1 month had significantly greater levels of all the anti-RBD isotypes in comparison to the baseline, and outpatients at 1 month. However, outpatients at 6 months have significantly lower levels of all anti-RBD antibodies compared to the 1 month. And lastly, looking at nucleocapsid, inpatients at 1 month had significantly greater levels of all anti-nucleocapsid isotypes compared to baseline, as well as the outpatients at 1 month. So again, we're seeing the exact same trend in the 1 month time point for all of the antigen targets. But more than 50% of the outpatients appear to have no detectable anti-nucleocapsid, IgA or IgM. And outpatients at 6 months had significantly lower levels of all anti-nucleocapsid antibodies compared to 1 month. So the anti-nucleocapsid response drops off rather rapidly, whereas the anti-spike and receptor binding domain response are being maintained over time. Next, we assess the neutralizing antibody response, and we see that 1 month post-infection, 100% of inpatient samples are positive for neutralizing antibodies. It is a smaller N value, but it is a significant finding. And we see that the median percent neutralization of these samples was significantly greater than at baseline, as well as to outpatients at 1 month. There was no significant difference observed in the distribution of neutralizing antibody responses between outpatients at 1 and 6 month post-infection, which suggests that there is a durable neutralizing antibody response over time that is maintained for at least 6 months. The last analysis that was performed on this cohort was a quantile regression to identify associations between patients' SARS-CoV-2 antibody response and clinical characteristics that included sex, age, ethnicity, BMI, smoking history, lung problems, and viral lineage. We only found associations with age and BMI, which are the two graphs I've shown here. And after adjusting for sex and BMI, outpatient age and BMI were positively associated with higher total antibody spike antibodies, which is not overly surprising, right? Given that these variables are correlated with increased risk of hospitalization, the increased antibody levels may be a protective response in the outpatients to try and prevent this hospitalization. Next, we're going to look at antibody data that compares results for the groups shown in red. The vaccinated group data is still being analyzed, but I'm going to heavily discuss how the hybrid and breakthrough data compare to the infection alone. So recall the cohorts that we have, which include infection alone, breakthrough, which is receiving a vaccine and then becoming infected, and hybrid, which is getting vaccinated first and then receiving a vaccine. So the total anti-spike antibodies is performed on the Roche assay, the right-hand side for each cohort at the 1 and 6 month time points post-infection. And the horizontal black lines indicate the cutoff for the positivity of the antibody level. So here we see that breakthrough and hybrid patients show significantly higher antibody levels compared to the infected alone cohort at both the 1 and 6 month time points. Furthermore, we see that hybrid patients have higher antibody levels than breakthrough patients at the 6 month time point. Next, we broke down the analysis in the group by looking at the antibody antigen targets. And so here for the RBD IgG, we have the same findings that breakthrough and hybrid patients have significantly higher antibody levels compared to infection alone at 1 and 6 months, and that hybrid patients have higher antibody levels than breakthrough and infection alone at the 6 month time point. Here we're looking at the same data, but we break down the breakthrough and hybrid groups based on the number of vaccines that they received. So on the x-axis, you can see the breakthrough group has received up to 3 doses of the vaccine, and the hybrid group has received up to 2 doses of the vaccine. So for the IgG-RBD antibody levels at 1 month, the breakthrough group has significantly higher levels of antibodies when compared to infection alone, regardless of the number of vaccine doses that were received. But when we do this breakdown at the 6 month time point, we lose the significant differences between the cohorts. When looking at the spike IgG, the breakthrough infection again shows higher antibody levels compared to infection alone and hybrid. But interestingly, we do not find the same significance at the 6 month time point, which shows similar antibody levels across all of the cohorts, although the hybrid group does show an increase in levels over time. Again, when we break it down, we break down the breakthrough group and the hybrid group. The breakthrough group shows significantly higher levels of antibodies when compared to infection alone, with 2 or 3 vaccine doses, but not when 1 vaccine dose is received. And the hybrid group is not significantly different than the infected group alone, but does increase in antibody levels over time. Lastly, when looking at the anti-nucleocapsid results, we see opposite findings where there's a significant decrease in the breakthrough infection compared to the infection alone and the hybrid group. And the positivity for anti-nucleocapsid in all cohorts is almost negative in all participants at 6 months. A few participants showing some positivity. Again, when we break the breakthrough and hybrid cohorts, the breakthrough group for IgG nucleocapsid shows significantly lower levels of antibodies when compared to infection alone, when 3 vaccine doses are received. And although we see the same trend for 1 or 2 doses, the results are not significant. The hybrid group is not significantly different than the infected group alone, but does increase in antibody levels over time. When stratifying the cohorts by age and splitting it at age 60, we see that there is significantly higher anti-RBD IgG in the infection alone group for older patients, but we do not see this response in the breakthrough and hybrid group, suggesting that there is some sort of vaccine-induced immune response that's different in different age categories when compared to just having an infection alone. When we stratify the data by sex, we do not see any sex-specific differences across any of the cohorts for 1 and 6 months, which is also in line with other literature as well. Lastly, when looking at correlation of different SARS-CoV-2 specific antibody responses compared to neutralizing antibody levels, we see that anti-RBD and anti-spike levels correlate very strongly with having neutralizing antibodies, but anti-nucleocapsid did not show great correlation at 1 month. And again, when looking at the 6 month time point, correlations remain similar, but we see significantly lower levels of neutralizing antibodies. So overall, the GENCOV study links laboratory and patient characteristics to provide a comprehensive understanding of factors that contribute to variability in COVID patient outcomes. I hope I was able to show you today that there's increased odds of hospitalization in patients who are older, who are non-white European, have higher BMI, viral variants, or hypertension. Commonly ordered and abnormal biochemistries and hematologies in COVID inpatients included tests associated with liver function, blood gases, cardiac markers, coagulation, inflammation, and acid-base disorders. And participants who were females aged 18 to 44 with higher education and higher household income had better understanding serological testing and antibody response, although were unable to explain the sex differences observed. Vaccine naive inpatients at 1 month have significantly higher levels of antibody levels across all isotypes, antigen targets, and neutralizing antibody ability when compared to the vaccine naive outpatients. Outpatients' age and BMI is positively associated with higher total anti-spike antibodies in vaccine individuals. I showed that breakthrough and hybrid patients show significantly higher levels of antibodies, particularly spike and RBD IgG, when compared to infection alone in patients at 1 month post-infection. And lastly, anti-spike and RBD are maintained for longer periods of time and correlate better with neutralizing antibodies compared to nucleocapsid. So with that, I will wrap up my presentation. If you are interested in joining our team, we're very collaborative. We work with a lot of different investigators, whether locally or non-locally. If you're interested, please contact us at gen.cov@sinaihealth.ca. If you're just interested in following our study, you can follow us on Twitter. With that, I'd like to acknowledge and thank everyone that is a part of our team. I'd also like to thank our funding sources, CIHR and more recently IFCC, as well as the in-kind funding that we received through Genome Canada and Roche, and Dynacare, who performs all of our outpatient blood draws. Thank you.
And Dr. Taher, I want to thank you for your time today and for your important research. And questions asked at this time will be addressed via email from the speaker using the contact information you provided at the time of registration. Dr. Taher, do you want to provide any closing remarks before we go? Because I didn't see any questions already coming in at this time.
I don't think I have anything further.
Well, I want to thank you again for your time, and I do want to thank our audience. And this webcast can be viewed on demand for 2 years until November 9th, 2024. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Bye-bye.